I'm Joel Berg. I'll be your moderator for today. I want to thank you for joining us for this town hall. APD leadership will be providing remarks, after which we will get immediately to all of your questions, which you've submitted. Very thoughtful questions, and there are quite a few of them, so we'll get to those. We'll briefly discuss logistics for this call, which will take place for about 80 minutes approximately. First, I want to give you a few of my own observations. I am grateful personally to have been given the opportunity to see dentistry and to see pediatric dentistry from many different perspectives over my career, from academics, from industry, from private practice, and in leadership. In the midst of this crisis, I have listened, I have watched the so many good things that many of you are doing. I have heard from many of you. You have written many really clear and excellent thoughts from new colleagues and from former colleagues about their personal journeys, their thoughts about what is happening, what might occur, what should occur, what will occur. We have learned so much, and I see how we all learn from each other. Each of you has taught me so much along the way. My prominent observations of you, my colleagues, is that you care a lot. You show up, you take action. We hear these times described as times of uncertainty. One could argue that every day is a time of uncertainty, yet we have been given a very large dose of uncertainty all at once. One thing is certain. We are here to help each other because we care about our patients, about ourselves, about our families, and about our communities. AAPD has been busy representing you in all that you value, what we all value. I know we will emerge from this strong and as productive as ever. I am certain of that. We may not know exactly what it will look like, although we will learn more each day and get closer to that ideal state. And each of us as a leader, collectively, we lead as the AAPD. I've always believed that leaders don't make change, rather they respond effectively and definitively to change. I see that in what we are doing together and as we have always done. So I'd like to get to our panel, and I will introduce our leaders, our panel today, and I'm honored to be with them. First, we're going to have Dr. Kevin Donnelly, our president-elect, Dr. Jessica Lee, Dr. Paul Casamassimo, our chief policy officer, and Dr. Jade Miller, AAPD past president and chair of the safety committee. So I'll ask each of the people in the order I introduced them to, starting with Dr. Donnelly, our president, to give some opening remarks, and then we will get right to your questions. Dr. Donnelly. You're muted, Dr. Donnelly. If you could unmute. Start over.
You hear me all right, everybody? I wanted to say good evening to all of you out there on the East Coast, and I guess good afternoon to the rest of you. I wanted to personally thank you for your patience during these trying times, and thank you for the care, primarily emergency care right now, that you're providing to your patients. Obviously, we need to take care of our kids. That's why we're on this. We love kids. And so I can't possibly extend my appreciation to you enough for doing what you can do for kids. I wanted to let you know that the AAPD leadership and staff have been diligently and continually working day and night. I can tell you all hours of the day and night, not just weekdays, but weekends and too, that I hear from Academy leadership and staff. And they're doing what they think is best for our membership. And I can assure you that it is. Certainly looking at the COVID-19 section of our website gives you an idea of some of the work that comes into this. You know, we're updating it continually, and that's really for you to follow along. We know you can get this information, some of it from the CDC, the Center for Disease Control and Prevention, from OSHA, Occupational Safety and Health Administration, and some from the American Dental Association. But what a nice way for us to put it on our website so it's easily filtered down to you for what we think is really critical that you know. I guess I wanted to make some specifics on what have we really done as an organization. And I think the first thing we did is we defined and interpreted urgent care and emergency care. And as you'll recall, that was really kind of where we were handed, many of us, by our governors here in the state of Texas. We were mandated to only provide urgent and emergency care. Then we moved on to sharing what the CDC and OSHA updates have had with you. I can't begin to tell you how many collaborative letters we have sent in conjunction with the American Dental Association, in conjunction with other medical associations, to try to guide the path of where we're going. And a lot of it had to do with considering you out there as small business enterprises, so that you could be a part of the small business loans as they came out. And of course, we've also had information on the Paycheck Protection Plan for you to see how to go about getting those dollars. And of course, the Economic Injury Distribution Loan, to help, again, you kind of follow step by step what you could do to submit to try to get help for yourself. So I think some other prominent examples would be that we're providing the latest recommendations for providing emergency dental care and minimizing risk to dental health professionals. We have guidance directives from your own state regarding safe and practice in dentistry, minimizing the risk of COVID-19. A lot of this came from, as you know, the CDC, but we've offered some ourselves. What about the PPE shortages? These personal protective equipment varies so much around the country. And I know for us here in Texas, it's a real issue. And it was most important, not only important for us to limit our care that we're providing to just emergency care for our patients, to have social distancing, but it was to preserve that personal protective equipment that we didn't have enough of, so that it could be used on the front lines for absolute emergencies, more in medicine, as they came about. We've worked with third-party payers. You're going to hear more about that. We continue to work with things for you to get reimbursed through teledentistry. We have made efforts for you to get reimbursed for potential screenings of your patients for the coronavirus. And so we have worked hard in a number of ways to try to have a lot of entities contacted so they know what the needs of you are in your practice. Now, I think one of the most important things we're leading towards is what can you expect tomorrow? And what may be terms to the testing and emerging as you deal with this crisis, and you move on to reopen your offices and provide elective care. I want you to know that I really respected the questions that came in. We got a number of questions, and I'm delighted about them. Sure shows that you're already thinking ahead positively of how you're going to reopen your offices. I wanted you to know that we probably won't have time tonight to answer all your questions. That doesn't mean we don't think they're important. Some of the questions, a lot of PPE questions, will be grouped together in infection control, but we are going to give you the best evidence-based answers we can with the information that's available at this time. One of you wrote in and said, well, are you really going to be able to give us exact answers with respect to all these? Well, we're going to give the best answers we can with the information that's available. But obviously, some of it's going to be our best guess, and a lot of it's going to be your best guess of things as they come down the line. As you know, we see changes every single day, and so I think you can appreciate that. I want you to know that this won't be our last town hall or correspondence with you. We continually update online our information daily. I want you to check with it as frequently as you can. Also, I recommend not only do you check with the CDC website, but things are happening differently around the country. We probably will reopen at different times according to risk assessment and information that's available at the government level. A lot of this will, well, most of this will be controlled by government officials. So you really need to be aware of what's taking place in your part of the community. So from there, I'm going to turn this over to our president-elect, Dr. Jessica Lee.
All right, thank you, Kevin. I certainly appreciate your comments. Good evening. I am on the East Coast, so it's 6 o'clock over here, a little bit after 6, but I understand that it's probably just a little bit, probably midday in the West Coast. To my colleagues and family that are in the Seattle and Washington area, thinking about you. And my last visit was actually to San Francisco, the California Society of Pediatric Dentistry meeting, and then all this happened. I am here to address, to the best of my ability, is what comes next. As president-elect, I will be inheriting this issue, and we will get through this issue together. Before we get into the details of what's next, I actually do need to recognize all the good that we've been doing as pediatric dentists in the midst of a pandemic. And believe me, this is a pandemic. I just need to take a few moments because we have done this. We've made tremendous sacrifices as pediatric dentists. We've offered up our PPE, several reports from hospitals. I know UNC hospitals have stated that was a game changer. So we're making these sacrifices. The precious PPE that we had in our offices, we've offered to our medical colleagues on the front lines. We have played a vital role in flattening the curve. We've adhered to social distancing. We've had stay-at-home orders. And yes, absolutely, we paid the price for this. And that cannot be underscored enough. We have made many sacrifices for the greater good. But I'm so proud of this pediatric dentistry group for doing that. So what does opening our practices look like? That seems to be the million-dollar question. And many ask for, what is the new normal? The truth is, it's not going to feel normal. It's different. We're in a different world. We will be doing this in phases. It will not happen overnight. I wish we could flip on a light switch and go back to March 12th was the last time we saw regular patients in our clinic. That's pre-COVID-19. And I realized that that's not going to happen. It's going to feel different. We're living in a different world now. And that is certainly a difficult thing to accept. And we would almost do anything to get to normal, but this will happen in phases. And it's going to be determined by your states, as Kevin mentioned. States are the ones that had implemented the stay-at-home orders, and they were the ones that will lift them. But we will work closely with the states and monitor what the states are doing. But the American Academy of Pediatric Dentistry still can work on issues. And yes, these are fluid times, and yes, things may change, but there's concrete, discrete things that we can do. One, we will continue to work with the ADA, the CDC, OSHA, and other agencies to inform the guidelines on PPE and when to open dental offices. Two, we will continue to advocate that dental care for children is a medical necessity. I know many of you felt put on the sidelines when people have asked to cancel your so-called elective cases. But believe me, they were not just because they were dental. There were elective cardiac cases, orthopedic cases, and others getting canceled too. But we will continue to advocate for the medical necessity of dental health for all children. Three, we need to go back to our basics. We need to emphasize the H1 dental visit prevention. And that we are the American Academy of Pediatric Dentistry, and our vision is optimal health for all children. Those basics will get us through this. We need to understand that prevention, and that starts early, because the children that had disease that we did not get to early enough are the ones most suffering now because we cannot treat them or restore the disease that they have in their mouth. Four, we will continue to work with the Research and Policy Center under the leadership of Paul Casamassima, our Chief Policy Officer. We will develop member resources that you need, whether that be toolkits, letters, anything you need to communicate to your population of patients. And we will also emphasize the work of the Safety Committee, which is under the leadership of Jade Miller. I will also be asking the councils and committees that will be meeting soon to develop charges to how we can address the COVID-19 situation. There are probably 200 of you out there that received your appointment letters today, and I certainly hope you'll you answer the call to action and help us out with this. We need you at this time. We will continue to disseminate information in the form of podcast CE. Look forward to our new pre-con course on how to start your practice and webinars. Most importantly, we will continue to communicate, and we will continue to communicate often. As Kevin said, this is the beginning of a conversation, not the end. I was so excited to see so many questions that have come in, and we will not be able to get to all of them today, but we will try, but we will have more. And we will continue to communicate. It's such a need at this time when we feel like we're not connected to our colleagues that we're so used to being connected to. Lastly, I want to make a personal observation about the COVID-19 pandemic and why it might be hitting pediatric dentists particularly hard. I believe we, as pediatric dentists by nature or selection, are very social beings. We love to be in crowds of people. We enjoy each other's company. We laugh, we smile, we cry, we hug. And that has been taken away from us. And to me, that's a very scary thing to think about. And we don't know how long that's going to be before we will be able to do that again. I would much rather be with each of you in person having this conversation and not looking into a camera. We need to recognize that we have endured a traumatic event. All the data that's coming out of China would call this a traumatic event. So please be patient with yourselves. You all are amazing practitioners, amazing advocates, teachers, and you've gotten yourself, set up amazing lives. But we're also very used to being in control of everything and having all the answers for the people around us. And sometimes we just may, but you really need to be patient with yourselves. You will get the details of your practices worked out, and they will recover. The AAPD will help. It may be slow, but it will happen. What I worry most about is you, my friends, my colleagues. The personal recovery will be more challenging. So please remember to take care of yourselves. I'm going to hand it off to Paul Casmassimo, our Chief Policy Officer, to talk about the things the Policy Center is doing in more details. Thank you.
Hi, everybody. I'm trying to negotiate this. Can everyone hear me? I hope you're staying safe and staying 6 feet apart. So we can resume our practices when the time is right. So I am going to try to answer some of the questions that have been sent in, and as Joel and Jessica and Kevin said, there were many questions, and for many of them we don't have an answer. And so I'm going to do my best. I'll give you my opinion if I'm not sure of an answer, which is probably most of the time, because these things change every day. I get information from AAPD, from the ODA, from Ohio Dental Association, from the American Dental Association, from my own hospital and colleagues, and everyone's a little bit different. So as Jessica said, we'll do the best we can. So someone just sent me an email and asked me why I wasn't wearing a tie. And I sent all my ties. I only have a few left, but I sent them to be made into masks so I can wear those around the neighborhood. Okay, let's get started. And so, as Jessica said, the new normal is going to be different. And really the answer, as you've heard a couple times tonight, is no one really knows. We can predict change, but we really can't be sure exactly what things are going to look like. So I'm going to try to talk a little bit about a process more than specifics. These are some things you've heard before from me and from others. First one is keep up on national and state recommendations. Kevin said every state is different, and that's true. And these things change frequently. There are pressures on governments to open up business and practice. And so you see changes. We see advances in testing and those kinds of things. So it's a constantly changing landscape, and check on it. I say, like we say, brush teeth twice a day and see a professional. Get your information from reliable sources and check it twice a day. Let's approach this. One of the things I found very helpful in my own situation, taking a cue from one of our think tanks in Ohio, is to kind of create a chronology. So if you keep things on your computer and you can organize them in some sort of chronological fashion, it's very helpful to review, to have things in the order that they're changing, and to know what the most current recommendation is. The next thing I would suggest, and we all have a lot of time on our hands, unfortunately, envision you as the provider of care in your practice, and your footprints and your pathways through your day of practice, and then consider yourself, take a walk as if you were a patient and a parent, and walk through your practice and think about the opportunities for exposure, the things that you should be doing physically to change your practice, and just kind of do a walkthrough, a virtual walkthrough. And that will help you, I think, when things start to open up, what you need to be doing in your particular situation. Another thing, and I would say carefully and very carefully, let me emphasize that, read and evaluate the kinds of advice that we have on Little Tooth Talk and other chat lines from your colleagues. We've got a lot of smart and thoughtful people who are asking good questions and providing good answers. Think critically on what those are. They relate to clinical steps, employment issues, legal aspects of the new normal, and things that you may be able to use. But again, carefully evaluate those as you see those. Talk about things with people you trust, that you're experts about your employment situation, your employees, any liabilities you might have, health coverages, payers, employment rules, and all the elements of running a practice. Talk to your experts who I think would certainly want to be helping you in this period of time to make the best judgments. And if you follow the government regulations and new programs and things, there's a lot to keep up with. So go to the people you trust. And then the last thing, and this was a point made last night on one of our phone calls, was if you're sick, if your employees are sick, and if your patients are sick, tell them to stay home. Don't guess, don't try to say, I can get through this, it's just a little hay fever or something like that. You know, we need to do a better job as a country letting people use their sick time. Okay, I want to get into some clinical specifics as best I can. Listen to what I say, but be critical about what I say, and check it against the things that you've read and gotten from other sources. If you remember Ronald Reagan, trust but verify. So some of this is my opinion, some of it is information that I've gleaned from the various sources, but you may have heard different things in your state, and health authorities may caution you to do things differently. So I'm going to go through that. So first one is, assume that your patients will come back to your practice and they'll need care, and that there will be some kind of COVID screening. And you probably need to be thinking about how that will fit in your practice. Verbal screening, written screening. We may even be fortunate to have some kind of physical testing that's short term, and we can find out an answer in a very quick period of time. And there are a lot of sources out there. Hospitals and other clinics have examples of questions that you can use to screen patients. They're already out there, and if you have hospital privileges, you probably can get that kind of information. I mentioned earlier, envision how patient flow will be in your office, and make sure that your staff is protected with social distancing and that you can minimize patient-to-patient contact. Those are the new rules of the road. We'll probably, some people have mentioned things like staggered appointments, waiting in cars until it's time for an appointment, use of more liberal use of pre-appointment telephone triage to get symptomatology and communicate times and things like that. Anything you can do to minimize people-to-people contact as we get back to new normal will probably be a part of the new normal. Excuse me, another thing I think we have to recognize, and Dr. Lee is our the resident leader therapist, and she tried to make us all feel better, but we need to do that with our patients. We need to let them know what we're doing and communicate to them the steps that we're taking to make our practices safe for them and to encourage them to come back. So think about ways you can put this on your website, put it in your phone messages, and just let patients know that things are getting better and that you are working hard to keep them and yourself safe. One of the things that has popped up literally across the country is a recognition of the benefits of telephone triage and teledentistry. And I would encourage you to look at ways to make the use of telephone communication and teledentistry a part of your practice even after this crisis abates. The pediatricians do it, your physicians do it, a lot of people do it, and if you haven't made that a part of your practice, I would encourage you to use it now and to consider making it a part of your practice in the future. I think we need to think about our waiting areas now as simply passageways between the front door and the operatory. We don't need places for patients to sit and circle. We don't need toys. We don't need magazines, things like that. I mentioned earlier about having patients sit in their cars in the parking lot. It was pointed out to me by an urban pediatric dentist that people don't drive to his practice. So you've got to be creative in figuring out ways so that people do not have to come in contact in the process of getting a dental appointment. So those are just a few things. And again, it's the answers maybe are not clear right now, but they're evolving. And if you can think of this as a GPS system rather than a location to get to, I think it'll make your job a little bit easier. I'd like to talk a little bit now about some infection control things. Again, Kevin mentioned that masks and PPE are in short supply. A dentist I talked with last night said that he gave back most of his PPE to general healthcare to help people with the virus in hospitals and protect our healthcare workers. You may have had the same experience or have chosen to donate that. So the first thing is spend a little time verifying your supply chain and look at your inventory, look at where you get your products. Make sure that you can get those and maybe even start getting some of those geared up for your practice. But supply chain issues have plagued our country and other countries as well. And it's something we seldom think about and take for granted. The N95 mask situation is today it's one thing, tomorrow it's the next thing. My recommendation is to follow the advice of the American Dental Association and the CDC in terms of when you should use N95 masks and how they should be used. Hopefully you can get those if you need those. A company in Ohio, an engineering company, has created this device that can sterilize thousands of these at one time. I don't know, they may be in better supply, but they're really, I don't have an answer to people who say I can't get them because they really are hard to get. I'll move on to the next. There's some evidence that mouth rinses with peroxide pre-treatment can reduce pathogens. But I would say hopefully you've screened your patients well enough that the kids who you're seeing in your practice are at very, very low risk or no risk at all. A lot of talk has been given to aerosols. They're the new culprits of infection control, and a lot of questions about masks and being able to control those. Unfortunately for us, and I don't have an answer to this, how to control those. We've seen these devices that are made to suck out air and aerosols. I don't know that we have good data on whether those work, but remember, we have little kids who sneeze, cough, they cry and they heave, they spit, and they really haven't acquired a lot of the social norms of stifling all of those bodily functions. So even without the use of a high-speed handpiece, we're going to be dealing with aerosols. And so we've got to figure that into things like just routine preventive care. And remember, air-water syringes generate aerosols as well. And so just washing and drying teeth can be a problem. I don't have an answer to that. Hopefully, as time goes by, we can have better information for you. Here's a few more things as I finish up. Question was, will we need negative pressure rooms? I doubt it, because if every dental practice in America needed one, it would just shut us down. So I think what we'll find is centers will be developed that have those if someone in fact needs to have that. Will we need high capacity aerosol reducing vacuums? I don't know. We can't even get enough respirators and ventilators, so I don't know how we can fit every office with one of those things. Will we need hazmat quality PPE? I think it's unlikely for most patients, if not all of our patients. I think we'll go back to maybe a slightly modified PPE setup, particularly after the COVID-19 pandemic drops off. Will we need to be vaccinated? Probably we should, and our staff as well. It may be a requirement for employment. Those are things that have come up in the business side of this. Should we and will we need to test our patients? That's another question. The answer is probably yes, or if we're in doubt, send them to a specialized source of care to be tested. Someday, or maybe in the near future, we'll have testing available that we can have in our offices if we need to. Excuse me. Another big area, which I don't have time to go into, and I don't know, you can, is operating room and hospital care. My best advice is check with your facility. Every hospital has a slightly different take on who can be seen and what is an elective case, and what it means to generate an aerosol in the course of treatment. The other thing I would get people prepared for in the new normal is that we have a lot of medical surgeon colleagues who are also juggling a backlog of elective cases, and there will be a lot of competition for OR time in the very near future. So just be ready for that and plan accordingly. Another question is, should we be doing more interim treatments like intermediate therapeutic restorations or Hall crowns? And I can't give you an answer except to say that I think we all do what's best for our patients. We balance infection risk of traditional dentistry and aerosol generation with our confidence in some of these alternative techniques. Personally, I say I can predict the outcome of conventional dental care, and I don't really like the idea of having this growing population of children who have been treated with delaying tactics, but the data is not clear. So my comfort is to do traditional dentistry when I can do it. The last question I'm going to talk about specifically is open bays. If you have an open bay, and many of us do, space your patients apart. And I want everybody to realize that the open bay concept began to die with HIPAA. And if you were unaware of that, or if you're planning a new office, realize that actually sounded the death knell of the open bay concept. And this is just a nail in the coffin. So let me finish up real quick. I've taken a lot of the time here. Kevin and Jessica have pointed out that the leadership has been working on this crisis since day one, and I would encourage everyone to follow our website. It was the safety committee was mentioned, and I'm going to let Dr. Miller talk about that and what is coming from there. The last thing I'll talk about is that we are taking the position that we're not going to stop dealing with the problems and the shortcomings of our system that have appeared in this crisis. We've already made appointments in contacts with CMS in Washington that runs Medicaid, and with the CDC to talk about the future and the new normal, and to be sure that the changes, if there are any to be made in how we practice, take safety into consideration, as well as the realities of a system of private practices that take care of our children. So I'll stop there and turn it back to Joel.
So we're going to go to Dr. Miller next, please, Jade.
All right, thank you, Paul. I'm just going to emphasize that it's important to understand we're in uncharted waters, and we are currently operating our dental practices in virtually every state under interim guidance that the CDC has established and that most of our state dental boards have established. And essentially those are emergency or urgent care. Now we expect these guidelines will be updated and revised as we've seen as new information and data evolves. We also need to understand that the current recommendations may not be relevant once this crisis is over, but as has been mentioned, things will be different. We will have new information that will influence what the future will look like. Even though right now, as you look at it, it seems like it's impossible to reopen the dental practice. But as things evolve, things will be different, but I don't see where they're going to be impossible. And another thing that we need to take into account is changes in technology. These changes may make less intrusive requirements possible and also give us options that we currently don't have available. So I think the technology is going to be a key part of helping get back to the new norm. Paul had mentioned the safety committee, and I want to share a little bit about the AAPD's commitment to our members to keep them informed. In 2016, the AAPD made a commitment not only by creating a safety committee, but by contributing and committing resources to that committee. And so they've really raised the bar with our commitment to safety, and that was 4 years ago. So a few of the things that we have seen is they made it a significant priority. And as the committee has begun and continued to produce some resources for our members, we're seeing that obviously things are always evolving, and we are committed to staying relevant with the current information. And as you can see, with this crisis, things change daily. Safety is an all-encompassing part of dentistry. It virtually affects everything that we do. Many of you were in attendance in November of last year at our safety symposium. That was our first symposium that was focused on safety. And now the world's a whole lot different after that symposium. But some of the topics that were covered then were just the culture of safety. Other industries that were at the forefront, like aviation and the space industry, how did they integrate safety at the level that they've done that? We discussed safety and sedation, the legal aspects and ramifications. Also, where's dentistry at today, and what is its evolution going to look like? We also had some presentations regarding materials and device safety, and then finally cyber safety as well as patient records. So as you can see, the safety topic touches virtually everything we have to do in our practices. Now these resources will continue to become available ongoingly. You've already seen some of those. Like I'd invite you, if you haven't listened to the podcast, there's a lot of fantastic information. One of them is Dr. Molinari, who's a guru on infection control. He produced a podcast. There's also, Joel has hosted a number of other specific to this crisis that we have going on. So not only the podcast, but also I hope you've seen some articles in PDT, and we're also going to be launching an online resource called a toolkit, which will be a dynamic toolkit of resources for our members that what they can utilize. And that's going to be something we're not going to have everything in place at the beginning, but we want to roll that out and continue to grow that and keep that updated as things change. We're not going to create a resource like our resource manual, but there'll be topics and links that you can link to for the experts in those specific areas. Also, safety topics will be present in virtually all of our future annual sessions. And as was mentioned, clearly no one has the answers will be necessary when this crisis comes to an end. But the AAPD is working with our partners at the ADA, our sister specialties, and national health organizations to provide guidance as things evolve. As was mentioned, the ADA is one of those great resources for dentists in addition to the AAPD's website. They have algorithms and flow charts on how to provide care in emergency and urgent situations. So again, use those resources. You'll see guidelines from the AAPD and other resources, but as was mentioned, it's really your state and local agencies and dental boards that really have the final say, because things vary in each state, not only the degree of the disease, the timing of disease, it's different throughout the US. Most of this has been mentioned is out of the control of the AAPD, but we've made a commitment to give recommendations to those national agencies in the hopes of reducing an overreaction to the future requirements, because I'm sure all of you are concerned, what's the appropriate reaction and what's an overreaction. We will do our best to help give our recommendations to those national agencies. Also, we'd all like a cookbook on what to follow once we move through these interim guidelines. Unfortunately, there is no cookbook, as Paul's mentioned, but continue to look at those websites and national organizations for guidance. Lastly, today I saw the ADA, as we have established more of a task force in how to move forward as dental practice recovery. You've seen that our virtual pre-conference course that's going to be coming up will really be on how to make that movement into the new norm, so to speak. But also the ADA has established a task force to provide dental practice recovery guidance. And so we're in close connection with our various stakeholders. And Paul has mentioned that we're shooting in early May to have a clear roadmap from our safety committee on what that roadmap will look like as you begin to open up your practice in those various stages. And ultimately, as dental healthcare workers, we're at very high risk or in a high risk category as you look at where we fall at risk in either getting this disease or being a carrier in disease. And you may have guidelines as dentists that will help you determine how to provide the appropriate care. But really, it's you as dentists and your and what you feel is going to be best for that patient, with really the overarching goal of safety for the patient families that we care for. And as mentioned before, we'll get through this together. So Joel, I'm going to turn it back to you. And I know there's some question and answers. Paul has given a lot of those, went through a number of those questions already, but I know there's a bunch more.
Yes, thank you all very much. So in looking over the questions that we received prior to today's town hall, my first glance was that about 60% or so were about infection control. Actually, it's much higher, as you would expect. It's really, if you look at the category completely of infection control, probably 85 or 90% of your questions, understandably. So, and Paul has sort of answered that in terms of that we're going to be on top of it, whatever the recommendations are. We are going to provide those in a concise way to you, so we know we won't have the checklist necessarily, but we might be close to it. And I suspect we'll be at the state of the art, at the cutting edge very soon on whatever evolves. The other part of that, and Jade, you alluded to this, and this is related to a few questions, is not just what we will be doing, but what is the APD doing now from an advocacy perspective? And you were talking about, making sure that we are safe for ourselves and our patients, but we don't overdo it. We don't overdo the recommendations to make it too complex, too costly. So I'll just pose the question that was asked. Please address how the APD is currently advocating for pediatric dentists to become prioritized in the distribution of N95 masks. This one is about not preferential treatment, but the fact that we see more patients in a day. When I talk to my colleagues about in other disciplines of dentistry, perhaps we and the orthodontists, although we generate more aerosols, are in the category of seeing more people per day at risk. So what are we doing to make sure there's a prioritized distribution of N95 masks and other items that would be needed for us? And maybe Jessica, since you're the incoming president, maybe you want to start with that answer, please.
Sure, Joel, thanks. This goes to the data that's coming out of China that would say that the ophthalmologists, the ENT, and the dentists are probably at highest risk because we're in the area where it's got the greatest viral load, and so that's the area that we work in. There's actually some good news, I think, about the N95 masks. About there's a tremendous supply shortage for sure, but we've seen the flattening of that curve too. What's happened is that the demand went up so high and it peaked with a very steep slope, and the supply chain did not keep up with it. But there's evidence now that supply chain is actually opened up. Many of you guys probably heard that the boats from the ships from China actually, were some of the first to launch 3 weeks ago with supplies on it, and that usually takes 4 weeks to get to the US. So there's a loosening of the supply chain that's coming to the US. And there's also a flattening of the curve for the need to use the N95 mask. So I think that when we get back to our practice, I don't see it being that much of an issue. Right now, we had the perfect storm. We had this very steep slope of disease happening that we could not keep up with, that we were not prepared for. And then we also, so that was the demand for the N95 mask. Then we also had the shipments that were not coming in from our suppliers. But both sides of that is evening out. We don't have the steep increases. We do in some parts of the US, don't get me wrong, but the supply from the areas that the distributors from the N95 masks, everything points to that's actually opened up. So dentists, I think, have always been a priority. In our hospital, we were prioritized with the ophthalmologists and with the ENT. We were the high risk surgeons at UNC. And so I think what's going to happen now is that now that we've seen the flattening of the supply curve, the demand curve actually, that we will have it accessible when we open our doors.
Thank you very much. And I'm hearing that too. When you talked about supply chain, and I'm hearing from a lot of people, especially in the dental industry, who is hit just as hard as practitioners are, of course, that the supply chain disruption is really one of the key outcomes across the board, across all industries. Even in our business of education,
Mm-hmm.
the education business has been disrupted. Continuing education is disrupted. Dental education is disrupted. Along those lines, another group of questions was asked regarding education for all of our students, for all of our residents. What's going to happen to them? Many are intending to graduate, and they will at the time intended, and to get their jobs and to get going. We have board issues, things like that. I think we're fortunate here on the panel. I just realized we have 2 former CODA commissioners and 1 current one. So maybe I could just ask Paul or Kevin to address what is the commission doing, and what kind of shape are we in regarding getting our residents completed on time?
Well, I think I can handle that one, Joel. I was appointed to a special task force on the Commission of Dental Accreditation, who is working closely, as you know, it falls under the Department of Education, on our final review. And I have to give credit to the Commission on Dental Accreditation, and Joel can testify to this, as he is now our pediatric dentistry commissioner. But they have worked diligently with the Department of Education to try to make sure our residents can finish. And I think what we have found is the best news for all of us is we're competency-based educational curriculums. And so what we have to do, and the Commission on Dental Accreditation has already sent this out to all program directors, is a special form that you fill out to say how you are meeting those competencies in education under this new scenario that we have. And obviously, a lot of us are doing things online right now. And it's been great to see the country the way it is. A number of groups have worked together to help provide continuing education, didactic education online. And so I foresee that we will see flexibility and we will see residents graduate on time because of that. Is that what you're interpreting as a commissioner, Joel?
Yes, yeah, I think we've provided the opportunity for the programs to be in compliance with the standards through demonstrating alternative means of education. And I'm very pleased that that opportunity exists, so we're taking care of our students and our residents as a commission and as a community. Yeah, thank you. So that was one pretty big category of questions. Paul did address the general process, and I like that because we don't know exactly what the checklist of procedures will be, although I suspect it will evolve in terms of infection control. That's where most of the questions are. And we're going to know that pretty soon. We're going to know, maybe we'll have some kind of triage, tree structure. If this, then that. You know, there'll be questions perhaps about aerosols this, non-aerosols that. One of the things we don't know is what is an aerosol and when is an aerosol? You know, I've seen, there are a lot of questions around that. So I want to ask one specifically in that category, which was asked several times regarding prophies. Are we going to have to do toothbrush prophies initially only? Or, you know, again, I know it's the caveat of not knowing what the protocols will be, but if anybody on the panel want to chime in on that one? Maybe Paul, is that something that you'd like to take? I'm looking at you.
Sure. You know, I don't know the answer to it. Many years ago, I did a study of children with asthma, and just getting a prophy generated enough aerosol to reduce their lung capacity significantly. So they actually went into a state of asthmatic stress that required them to get to use their medication. So there is some aerosol issue there with prophy. I would hoping that we and I mean by we I mean the 3,000 people on this webinar can do some brainstorming and try and figure out how can we do a prophy that's effective and achieves what we want without generating major aerosol. And if we do generate some aerosol, is there a way that we can evacuate it out? And I don't have the answer to that. I think I've seen enough little tooth talk and other suggestions by people that are actually very creative and may in fact solve these kinds of problems. So I don't have the answer to that, whether we do it or not. Many of our patients, fortunately, can get away with a toothbrush prophy. And so, you know, that's another consideration, is to make that evaluation at chairside. That's only part of what we do at a recall visit anyway. So
That's right.
the last thing I'll say, and I don't know this would make people feel better or worse, but you know, in surgical care, in medicine, there is a lot of concern about aerosol, and it's not just the microorganisms in aerosols, it's the kinds of debris that are generated. We cut up old restorations, we cut tooth structure, we send up you know, blood components and tissue components into that aerosol. There's a lot of nasty stuff in there, and if one good thing comes out of this crisis is for us to really look a lot more in depth at what exactly is in the aerosols that we generate when we get in there and start really cranking the high speeds and drilling on teeth and old restorations and things like that.
So if I can jump in a little bit
Please.
and add to that, I think Paul brings up a very good point, and the idea of what's aerosolized and what's not is kind of seems to be the question of the day, and what can we do to minimize that? There is some differences, and not to get into the science between aerosol and a droplet. It's 50 micrometers, and so the thing that's so tough about the coronavirus is that it is an aerosol. Droplets usually, once it's kind of pushed up into the air, they usually fall to the ground, and gravity can actually take that. With aerosols, they stay in the air. One thing, our best thing against the aerosol right now is our high-speed suction. The early data would say that it could pick up 90% of the stuff that's aerosolized. Now, that's not 100, so I'm not saying that, it's the end-all be-all, but that's one of the best things we have that protects us against the aerosol is the high-speed suction. And so that should be something that we really do consider. And I also want to make the point that the best evidence at a recall appointment is our exam and the fluoride use. I mean, that fluoride is if I had to pick one thing, that is something that we should emphasize. And yes, we may have to modify the Pro-Fee or toothbrush Pro-Fee or use high-speed suction, but there's still things we can do. And, it's anticipatory guidance, it's an exam, and fluoride. And those are some of the best things. We've got really good evidence on all of those things.
Some have suggested, and I haven't seen it in these specific questions, that practices may choose to identify specific days when this is a non-aerosol generating day, to manage the environment very
Correct.
Specifically on those days. Have you heard about that, and does that make sense?
Yes. So I have heard that being discussed, and that, there'll be just days where, we are going to do baby infant exams, or we're going to do intake over teledentistry, and then come in and do the exams. So, and then really minimize the days that we're going to, and target the days that we'll be doing the procedures that produce a lot of aerosols. And it's really understanding the level of aerosols that you will produce. That's in an environment that we are assuming that we don't have a good testing mechanism for COVID-19,
Right.
So you have to treat everyone that's, suspect or a person under investigation, right, is what we call them at UNC. But, in time, there will be a good testing mechanism. One thing we didn't mention that we failed to mention between all of us is that, the CMC, the Code Maintenance Committee, met yesterday in an emergency meeting to discuss codes for antibody testing in a dental office. And so, that is where we're headed, and to a certain extent. I know that seems kind of out there and futuristic, but that is how you really rest assured that, whether or not the patients can pass on COVID-19 to you, other patients, or your staff. But there are ways to manage a practice and schedule a practice too in the interim, to have days that lower the risk. You're never going to be at zero, but it would lower the risk for sure.
And I think each of the answers to any of these questions obviously is a phased in thing, because, we're going to be doing it one way for a couple of weeks and maybe a month, and maybe it's a period of months or longer until we get, then there's a new normal. Perhaps there's a new normal, just as there was, I'm old enough to have participated in the care of HIV positive patients, HIV positive hemophiliacs, prior to us knowing that it could not be transmitted through aerosol. So we assumed that it was. The fear level was similar and the outcome was worse for the patients. So, we figured it out. That was different in terms of how it was transmitted. However, technology and evolution will change this for the benefit of all of us, especially our patients and our staff and our team. I wanted to get into another category of questions. And it relates to, and everything is going to be phased in, obviously, but there were a lot of questions about the ability to do sedation in the office. And if I combine that question, those series of questions, with, as was mentioned, I think Paul mentioned about, kids coughing and spitting and bodily fluids, one could argue that if they're calm and sedated, that's less likely to occur. It's a more controlled environment during restorative dentistry. So it could be advantageous from that perspective if everything else is managed from an infection control standpoint. So comments on our ability to do sedation right away. And I know many are doing that now. They're compelled to do it for emergencies at the moment. Any comments on that?
Well, Joel, I think that, again, I think it's going to be a phase in, just like Paul described and Jessica also. And I think that we'll eventually get there. And I think as we sedate, we might be doing different procedures immediately compared to what we'll be doing 3 months from now. The one question that's been popping up all over that I've been sitting here is nitrous oxide. People are really interested in what are we doing about
That was
nitrous
my next question, so you can answer it.
Yeah, obviously that's going to be with sedation. Well, I think it's preferable right now to use disposable tubings and masks. I know where we're at, we use those, they're kind of almost like flavored masks that smell like cherry and things like that, and they're disposable, and we get rid of those. So I think right now, I think that would probably be the best thing you could do. Or you could also use, the tubing mask scavengers that they can actually be sterilized. Most operating rooms, if you're in there, have disposable tubing, so I don't think that's a big issue to anybody in the operating room. It could be an issue in your practice. So am I telling you to immediately change what you're doing? Well, not really, but I think we have to phase in again, because we don't know if you aren't not replacing your tubing, can the virus be housed within that? So I would be very cautious of that right now. I know for our emergency care, unless we're using disposable tubing for nitrous, we don't use it at all presently. And certainly I think that as time goes on, things will change according to who's got the virus, who doesn't, and et cetera, that we've discussed.
Thank you. Another category of questions related to this, and it was mentioned before regarding the suction, and I'm going to make that a little broader question to the extent that we're seeing a lot of promotions from industry to providers, to try to help us out, and providing either saying that this isolation technique is better for aerosols than this isolation technique, or that this higher speed vacuum is better than this vacuum that you currently use. What comments do we have? What evidences there exist for those in reality? Anybody want to comment on that?
We know that a droplet, which is TB, other things, that it's 50 micrometers or larger, gravity actually pulls that away from you. It's going to want to go to the ground. That seems to be a cutoff. So anything greater than that tends to get aerosolized. Any vacuum suction, I like the high speed, is going to pull that away from the air or away from
So you mean even a traditional high-speed evacuation system in most dental units?
I've heard some comments about the ISO dry or ISO vac units. Absolutely, that also helps. It's pulling it back. So I think any suction unit is going to be better than none. There's some others that are better, which is the high vacuum one, and that's the one that's been studied. It'll pick up 90% of things that are aerosolized, 90% plus. But anything is better than none, and the higher the vacuum suction, the better.
Okay. I want to shift gears for a moment back to advocacy. We talked before about advocacy for prioritizing PPE, making sure there's enough PPE, differential effects on pediatric dental practices. I want to talk about a question, a very thoughtful question related to what's going on with consumers. When we reopen, we're going to be doing it in phases. So just the fact that we can't do everything the way we did before is going to suggest to people, well, maybe it's not safe. They can't see me the way they used to. It's all different now, and it's a little scary. At the same time, and this was what the person asking the question says, that people are going to the news discouraging people from seeing the dentist. Maybe that makes sense in some cases. I don't think it does universally. Very slippery slope about the medical necessity. It's not as important. That medical necessity was discussed. So I want to put it from the advocacy perspective, how can the AAPD assist, and I know you are, related to educating the public about that we are doing state-of-the-art safe care. So I think, Jessica, you wanted to talk about this as well, so I'll turn to you.
Sure. Thank you, Joel.
I know that health literacy and talking to the public is your expertise, so that's why.
Thank you. It's now more than ever, we need to be communicating with the public. Now more than ever, we need to get the right information out there. Now more than ever, we need to let them know that it's a time to see your dentist, and it's time to see your dentist for preventive routine care. Because the things we would let get away from us, the disease we let progress, is causing problems right now in the midst of a pandemic. So we need to see you now. When our doors open, we need to see you now. We need you to see you for the routine care. We've got to make sure that you're healthy, because you never know when the next time a pandemic's gonna hit and you'll not be able to get to a dentist. Our job is to keep your mouth healthy and to prevent the disease that we can't treat some ways. You know, we can't treat maybe the way we wanted to. So our focus needs to be on prevention. And yes, we need to get that message out there. We need to get it done in plain language. And so I would argue that it's the most important time to visit the dentist, especially the pediatric dentist. These children need to get in. They need to get in early and they need to get in often, so we can prevent the disease that caused some of the crises that we're seeing in our offices with emergency care.
Thank you. I wanted to get in, and then Jade wants to speak, but I just wanted to mention, because we have so many questions, some outside the category, and we may not be able to, we probably won't get to all of them today. And Kevin mentioned we're going to have future interactions like this. But if people want to get information to the academy, to the leadership, is one good way to go to their district trustee. And the district trustees can kind of funnel it up to the organization because they have a local impact, a local interaction. Would that be a fair way of one conduit to get things to the APD? Because we have so many great ideas. We want to make sure we capture them. Kevin, maybe, is that something you would like to comment on? And then I'll go back to Jade.
Sure. I think it's great to go through your district trustee, and most you have your state PPAs and everything else out there that you can talk to, and all of these folks have access to the district trustee, who can then take it to the whole board of the academy. So I think there's several avenues. There's some even local societies that then can go to their state society to go to their district trustee. So I think there's a lot of easy ways to get to information to the academy.
Thank you. Jade, you were going to comment on the previous issue we brought up.
Yeah. The thing, I'd like to touch on what Jessica was saying and how critical it is. Not only what can we do at the APD level, but in your own practice, that's where it's so critical to communicate regularly and positively to your patients in an empathetic way that, you understand what's going on. We're looking out for their safety foremost, and that, we'll want to get them in to just prevent problems. So I think regular communication, as Jessica mentioned, is the key, so that when that opportunity does arise to bring them in for elective care, they're more likely to do that. And I'll also touch on the fact that you just raised and Kevin mentioned about kind of how to best get that information. We do have a lot of innovative and bright colleagues that are thinking even way ahead of us in many ways. So we would certainly like to hear what their solutions are, what their innovation is. From a safety committee chair, that's going to be important that we can disseminate those ideas that that really appear to be effective. So yes, please go through your district trustees and your local PPAs, and we don't have to wait for a period of time for them to get the information to the safety committee or to the leadership. They can do that day via email or communication. So feel free to really continue to provide us information.
Thank you. We had several questions, as you would imagine, related to the business opportunities, to the CARES Act, the $2 trillion, some of which is offering loans, the PPP loans. And there were several questions related to advocacy efforts on the part of APD with various governmental entities to extend the deadline, the June 30th deadline. I know in talking to a lot of very thoughtful owners of practices, and I've heard so many stories, individual stories, that some have decided to delay. They're waiting and seeing, depending on other circumstances, yet they don't want to miss the deadline to be forced too quickly to do this. So does anybody want to comment on what the APD is doing to maintain focus on perhaps extending that timeline?
They've read our mind. We are working on it as we speak, and we're hearing that was just the first iteration, and there was, whatever the 8-week window is that they give. We are trying really hard to get that extended to December at minimum. So we are absolutely working on that right now. We know it's an issue. It was, as any part of legislation that comes out fast and furious, it's not perfect. It's something, but we are working on making the changes and getting that extension. Absolutely, we hear you.
Yeah, and I think, you know, I have to mention, and somebody may want to comment that, because there were questions about this as well, that we've had such an amazing relationship with the federal government and with the legislature because of all of our advocacy efforts over the years, and the amount of time and energy and the volume of our members that go to DC every year to lobby on behalf of kids. And I think we're one of the rare entities that really is about our population. It hasn't been about us. And I think we've established the message, and I want to hear your thoughts on this, that when we go there to advocate, yes, we do well, but we do a lot more good. And I think that's well known in DC. Any comments? And then Jade, you may want to comment. You're one of our new attendees regularly in DC.
Yes, thank you, Joel. The AAPD has really been at the forefront in the effectiveness in Washington, D.C. with our policymakers. And as those of you that have attended the Public Policy Advocacy Conference, and here our colleague, Dr. Heber Simmons, who's been our advocate for many, many years, he has been so effective with the guidance and the direction of the AAPD, as well as our local public policy advocates in each state. That's really critical because as you know, most policy is local and most regulations are local. So it's critical to have your local and state PPA. But we do have an advocate that goes to Washington about once a month and meets with the various policymakers. And that's why we've had our success with Title VII. And as has been mentioned, probably well over half of our newer colleagues that are in pediatric dentistry wouldn't be in pediatric dentistry had it not been for the efforts of the AAPD and in assisting programs to grow and increasing the number of programs. And as was mentioned as well, that a program Dr. Casamassimo is very much involved with is a workforce study. We're really looking at about 2 years ago, exactly where are our needs. And we've realized that we don't really, our growth is not something that we necessarily need to focus on, but really how do we enhance and utilize money in other ways. So advocacy is something that we are very committed to at the Academy.
Yes, I think we're all aware of that, and it's going to help us a lot right now when we need to call people and say, hey, can you help us in this locality? Even at the local level, it's going to make a tremendous difference going forward. There were several questions related to third-party payments, and we're not going to have time to get into that, but we will address those, and we touched on it. But in the specific area of Medicaid, where our members are disproportionately providers under Medicaid, and of course, with the unfortunate situation of the unemployment and expected to be considerably high, or certainly in the next months ahead, many people will perhaps lose their health insurance and perhaps be on Medicaid. So maybe this is for you, Paul.
Sure.
You know, is it something we do anticipate? And then, of course, the balance on that is, yes, more people, but the same number of providers, the same dollar pool. You know, I don't want a disaster plan, but this is an area where our advocacy is also going to help, I have to imagine.
Mm-hmm. Yeah, and you know, it's there's been a lot of speculation, Joel. You and I have talked about this, and what will happen, and if people are in fact joining the Medicaid rolls, pediatric dentists are in pretty good position because over 70% of us are willing to see Medicaid patients, and so we're a ready source of care, and have made that commitment as a specialty. Another issue related to that is that hopefully the patients who come to us won't be like many Medicaid patients, Medicaid children who have had difficulty accessing care, and they won't have the tremendous needs that we often see with kids on Medicaid. And because one of the national problems that this crisis has made even more apparent is the loss of operating room time for pediatric dentists, and a lot of it has to do with reduction in Medicaid reimbursement for facility fees. And I was just on a call with some Michigan pediatric dentists and one of their hospital centers who, was trying to work with them to try to figure out alternatives because the reimbursement is so low. And now we're going to have our medical colleagues looking for operating room time to get caught up on their elective cases. So it's just a very complex mix of what will happen, whether employment will catch up and get back to where it was, and what insurance will look like. I mean, it's just almost too hard to predict what it will look like, but there'll be some waves and some surges of certain types as we emerge from this epidemic.
And I'm hearing from talking to thoughtful people outside the dental profession, the same issues that prevail for us, the close proximity to patients, whether we're an ophthalmologist or a dentist, exist in other industries, the restaurant business, many other industries. And I think, it's important that, that we look also at the broader community, and we're pretty innovative. We're very innovative people, all of us, and there will be solutions. We don't know what they are. It's uncertain and it's scary. Yet I'm hearing a lot of exciting things in the midst of this fear and chaos, but the only way out is through. And I'm grateful to be a pediatric dentist, that we have colleagues like all of those listening today and all of you to rely on each other. I want to just take the last few minutes here to say that my observation is we're going to be doing more of these, which is great because we have so many questions that need to be answered. And I think that's also important because we can't answer all the specific questions today. We're going to know twice as much tomorrow as we know today. In 2 weeks, we'll know 10 times as much. And we're going to hone in on that perfect spot, that sweet spot of where we need to be to make us all comfortable to emerge into practice. And that's the goal. And I know that, my colleagues here, along with all the great ideas coming forward, are going to get us there. And I think this concept of, having tentacles in all the different areas in the government and to our members, to us, all those great ideas coming in, consolidating that and then distributing a methodology is what we do best. We do that very, very well. And I see this doing that here. So I want to thank the panelists. Before we end, I'm just going to turn it to Dr. Donnelly, our president, to make some closing remarks, and then we are going to reconvene. Kevin.
Well, I want to thank all of you participants for joining us. I'm sorry we couldn't get to all the questions. I can assure you we'll be back, and that information will be forthcoming. I hope what you've seen today is that we are really working hard to try to get information to you the best we can. I speak almost daily with our executive committee. John Rakauskas, our CEO, is at the helm of the central office. Scott Litch reviews everything that comes out legislatively and helps us submit documents. Policy, geez, I can't thank you and Robin Wright enough. Christy's working, and you'll have more information coming from Christy on our virtual meeting yet to come. But I guess what I want you to know is AAPD will continue to be proactive, just like we're going to make recommendations to the CDC that can help guide our future. And you can still remember that you will pursue the goal of optimal health for all children. So thank you.
Thank you, Kevin. Thank you to all the panelists, and thank you to the many thousands of colleagues out there who inspire all of us every day. Thank you very much. We'll see you soon.
Thank you.
Bye-bye.
Be safe.